So thank you very much for the nice introduction, and I would like to show you some slides on treatment in colorectal cancer and how it has evolved over the last years. So because the majority of you are surgeons, and what you all know very well is that patients who have a resection for their liver metastasis have a much better prognosis than patients who have no liver resection or no surgery for their metastatic disease. So this was demonstrated in this very nice retrospective analysis which was performed at these two very famous institutions. And it was also confirmed, for example, as you can see at this right part, at the large cancer registry with 10,000 patients in England. Both analyses have one in common and one in disadvantage. They are performed retrospectively, and we don't know how much different patient population, so more or less extended disease, for example, have contributed to this different outcome. To come a little bit closer to the truth, Antoine Broquet, who is a Paris physician and was working at the Nordlingers Institution, when he was a fellow at the MD Anderson, he did this following retrospective analysis. Patients with advanced liver surgery, two-stage resection, so have the more advanced metastasis or disease, were compared to patients with chemo alone, but to make it a little bit more fair for the medical oncologists, he selected the patients who had metastatic colorectal cancer but who had liver-only disease, who responded to chemotherapy and survived for at least 12 months, who were young and had a good performance status, so who would theoretically have been candidates for surgery, and who had not an uncountable number of liver mets. And even if he compared this quite good selection of chemo patients to this very advanced group of patients undergoing liver surgery, there was still a huge difference in the prognosis. However, this gray curves here demonstrate patients who just underwent the first step of the two-step procedure. You can see two things. First, there was obviously no huge selection bias. These patients did even worse than chemo patients. And second, if you cannot complete with the second step, the first resection or debulking of the tumor has obviously absolutely no benefit for the patients. Because all these analyses have been retrospectively performed, it's very important that we have this prospective analysis of this prospective trial. It's an ERTC clock trial, and this clock trial randomized patients with metastatic colorectal cancer, liver-only disease, non-resectable, to either chemo alone or chemo combined with radiofrequency ablation. Because the trial recruited patients over a longer time, when bevacizumab was approved, it was amended that patients could also be treated in combination with the antibody in both arms. The trial was downsized because of the recruitment. 120 patients were enrolled, and here you see the primary endpoint, which was progression-free survival. So already in the first publication in Annals of Oncology, there was a significant difference for progression-free survival, but at that time not for overall survival. Now with long-term follow-up, you can see there's a huge difference in the long-term overall survival in these patients treated with multidisciplinary treatment or treated with chemotherapy alone. So this is a hazard ratio of 0.6 for progression-free survival, and the same hazard ratio was observed for overall survival in this cohort. It's the only prospective randomized trial that confirmed that the multidisciplinary treatment has a benefit for the patient and actually improves overall survival. Therefore, I think this trial is extremely important. So what an intervention was it here? Was it really radiofrequency ablation, or was it something else? So it was not this type of radiofrequency ablation you would perhaps think at the first glance. So in 50% of the patient had just radiofrequency ablation. The other 50% of the patient had a combination of resection plus radiofrequency ablation. Background is that the patients could consent to the trial before a planned resection, and if the surgeon detected that it's non-resectable, then he could intraoperatively randomize the patient. So 90% of the patients had not a CT-guided radiofrequency ablation, but a radiofrequency ablation during open surgery, few during laparoscopy, and only few as radiological intervention. So it was more or less a trial rather randomizing towards multidisciplinary treatment than to a CT-guided radiofrequency ablation versus chemo alone. So this slide demonstrates a little bit how excellent are the results with the radiofrequency ablation or this combined treatment. So this is the EPOCH trial comparing perioperative therapy or liver resection alone, and this is the CLOCK trial for so-called non-resectable liver metastasis that were treated in this multidisciplinary approach compared to chemo alone. Of course, these comparisons are scientifically not 100% correct, it's just to get an impression. So now I would like to discuss a little bit what is resectable disease. This is a topic that is mainly discussed from technical issues, which are important because if it's technically non-resectable, then you cannot resect it. So in this patient, the two metastases involve all three liver veins, and it's very clear that this patient can probably not be resected if there are no variants in the anatomy. So if we downsize the metastasis by chemo, one liver vein becomes free, and there are perhaps 30% of remaining functional liver tissue, and then the resection can be performed. So this is a rather clear situation. There are other types of non-resectability. For example, this situation, which is very difficult to treat. Theoretically, a liver surgeon could, if he has enough time and if he wants to do it, perform multiple atypical resections. Probably there will still be 30% left. Of course, no one would do it, but it would be possible. So the same applies if there was a very short disease-free interval. So you have situations where you can technically resect, but you have performed the last resection in December. He has now 6 new small metastases. Theoretically, you could do it sometimes, but you would probably not do it. So there's a second axis of non-resectability. It's according to these prognostic factors. And the problem is that if we want to give chemo and if we downsize it, the question is, have we now actually changed the situation? It's very unclear what is the right treatment in this situation. If you show, especially if this small metastasis disappeared, if you then show the CT scan to a surgeon, he says, okay, this CT I would resect if I don't know what was before. And we all know the studies of disappearing liver mets, but no one actually knows what is the right treatment here. And then we have the third axis of comorbidity, frailty, that is seldomly very systematically studied. It influences not only the medical risk of resection, it also influences the feasibility of chemotherapy to downsize, but also to give palliative therapy. Sometimes if a patient has a slight dementia, it might be easier to resect him because you have him under control for this 2 or 3 weeks. If we want to give an outpatient chemotherapy, we can much less trust that he will follow the instructions. So, but if we go back to these 2 axes, we have such a map of technically non-resectability, poor prognostic factors, situations where patient who is perhaps borderline technically resectable because he has more poor prognostic factors, we would always decide against surgery. And this makes it a little bit more complex and more difficult to study. For the axis of technical non-resectability, you could do staged resections, portal vein embolization. You can combine it with radiofrequency ablation or with other ablative techniques. We can give conversion therapy, and here we have chemotherapy only to improve the situation, and it's very difficult. So I can even imagine, and we applied for a grant of a trial where we select this group of patients who are technically resectable but have poor prognostic factors, so many metastases, to randomize them to surgery or to medical treatment alone, because we don't know what is the right treatment. Now, what is our summary? Should we offer resection to patients? Yes, we should. Do we have good data for resection? In general, we have. But do we have good data for patient selection? So which is the right selection for against, or we're at the border of resectability? Absolutely not, especially not for the advanced situations. It's widely accepted to resect patients. My practice is rather to discuss resection and rather to recommend it, but I think it's extremely important to stay realistic. Also, if you recommend conversion therapy, because if you actually give conversion therapy, it will be much harder than the usual palliative one. And we should not forget that the patients needs to be rediscussed after 3 or 6 months. We will see it later in the CT scan, in the slides, because we might perhaps miss several patients where we could resect them. So now we would discuss in few slides. So if a patient has resectable disease, do we have to give chemo, or is it better just to resect him? So there are very few prospective trials. This is a combined analysis of 2 adjuvant trials, both performed with bolus 5FU versus observation. Both stopped early due to poor recruitment. Both were performed in the early 90s. This is adjuvant treatment, this is surgery alone, p-value 10%, so it's a strong trend, but not more. So after this trial, it has become much more difficult to randomize patients for or against adjuvant therapy. Everyone had his own opinion whether it's helpful or not. And then there was the ERTC trial. You know that for progression-free survival, it achieved borderline significance with a p-value of 4.5% in the first analysis and 7% in the second one, with a very small difference in progression-free survival, which is debatable, but which is there. So the trend is there, and it makes it a little bit more complicated. For overall survival, I think everyone would agree that there is no major benefit for overall survival. There is a small trend, but no major benefit. Which makes it complicated is the trial was never designed to detect a difference in overall survival. So we cannot conclude that because there is no demonstrated that there is actually no, because the trial was too small to demonstrate it. But at least in this group of patients, 2/3 had metachronous disease, half of the patients had one single liver met, CEA value was normal in half of the patients. So this majority of the patients had one single metachronous liver met. In this very relatively good prognosis patient, there was no major benefit to overall survival. Good prognosis means after 5 years, 50% of the patients died. So if we go a little bit more into the data, to the subgroup analysis, there was one multivariate model which included the baseline parameters, and they looked were there any interaction with the treatment effect. And there were 3 parameters that interfered with the treatment effect, and this was CEA. Patients who have a normal CEA have at least no benefit, perhaps even a detrimental effect. Patients with elevated CEA had a hazard ratio of less than 0.6, which is quite promising. Patients who fulfilled the inclusion criteria for a clinical trial but had a slightly decreased performance status had a rather detrimental effect. Patients with excellent performance status, a hazard ratio of 0.6. This is always for progression-free survival, not for overall survival. And patients who were obese had a rather detrimental effect. Normal weight or just overweight patients had rather a benefit. This is a little bit more difficult to interpret because there was a dose capping. So with more than 2 meter squares, the dose was capped. So at least in Europe, if you have a more heavy man, he can have 2.3 or even 2.5 if he is actually obese. So they might have been treated with an underdosed chemo. So I think this is very interesting. Patients who have a normal CEA and patients who are elderly and have comorbidity and have good prognosis have probably no benefit from perioperative treatment. If you have patients with excellent performance status who have a higher risk than one metastasis with normal CAA, have probably a higher benefit from perioperative treatment and might perhaps rather benefit from it. These are hazard ratios for PFS. So will we get more data and can we have more data? Probably not. We designed this trial, CAPOX versus no chemo as adjuvant treatment before the ERTC trial became public. These are other trials to compare perioperative versus adjuvant therapy in different settings. There are trials to investigate bevacizumab. This is in vaccination. This is a different antibodies or antibody-free treatment in perioperative setting. This is adjuvant treatment in different situations. All these trials have one in common. All of them are closed due to poor recruitment mostly. So we will not have more data in the next future. To me, very promising into what might guide us in the future is this Australian investigation, which is a side study or a side publication to a stage 2 publication. This was presented at ASCO only. These are less than 40 patients, so be careful with the interpretation, but it's exactly the same as for stage 2. What have they done? They determined the mutational status of the primary tumor. So, for example, whether there was a RAS mutation or an APC mutation. Then they have taken a blood sample for plasma and have searched for the same mutation in the circulating or in cell-free DNA. Whether there is circulating tumor DNA. If they found it, the patient had this prognosis for recurrence-free survival. If the plasma was free of circulating tumor DNA, they had this prognosis. So this is a hazard ratio of 13. In stage 2 it was 20. Such hazard ratio are quite seldom in such a discrimination by a test. We have to see whether this will be confirmed by later investigations. At the moment it's much too early to implement it into the daily clinical practice based on this very low patient number. But I'm quite confident that we will see more data in the next future. So what have we seen in this extremely good risk group? There's perhaps no real need for adjuvant treatment, or there would be need but no benefit. If the risk is a little bit higher and the patient have a good performance status, probably FOLFOX has a higher contribution than on the slide. And if we sum up the data, do we have real good data for perioperative or adjuvant treatment? No, we don't. Will we get better data in the next time? No, all trials stopped early. So do we have very good subgroup analysis for simultaneous disease? Not, but they might perhaps be rather high risk, although they're rare in the model. It is widely accepted to give perioperative treatment. For medical oncologists, at least in the French-speaking part of Europe, absolutely yes. In other parts, a little bit less. My practice is rather to give neoadjuvant treatment. We will see later on why. If we have patients with a little bit higher risk. And to think on adjuvant treatment in elderly patients who had a good outcome of surgery. So in the elderly patient, surgery is so much more important that I would not, let's say, harm surgery by the medical treatment. I think it's very fair to inform the patient on our limited knowledge regarding the benefit of an adjuvant or perioperative treatment. And we have to explain them that the likelihood for a major benefit in this very low-risk patients is relatively low. And if we have started with a neoadjuvant treatment, the patient was resected, and he has some complications, we should have in mind that it might be not extremely important to complete the adjuvant treatment. At least in stage 3, it was considered to be ethical to randomize 10,000 patients to 3 versus 6 months adjuvant treatment. So I wouldn't say that I would skip it if the patient can tolerate it very well, but you have sometimes patients who have a slightly decreased performance status after surgery, and where you have the feeling that it might be very difficult to complete the treatment. Now I would show you some slides and thoughts on prognosis, timing, and scheduling if you have planned multiple interventions. So first, if you want to give neoadjuvant therapy, how long should we give it until resection? And when can we achieve resectability? So for this I would like to show you the time to resection of the Salem trial. In Salem we have randomized FOLFOX cetuximab versus FOLFIRI cetuximab. Response rate was close to 70%, and 1/3 of the patients had an R0 resection. 45% were resected with any kind, so R0, R1 plus ablation or something else. According to protocol, the first evaluation for resectability was planned after 4 months. So you see some patients were resected a little bit earlier after the 2-month CT scan. Majority of the patient was resected after the 4-month CT scan. Some additional patients were resected after the 6-month CT scan. But if resectability was not achieved after 6 months, it became quite unlikely that further treatment still led to resectability. So if you haven't achieved it after 6 months, it's probably time to rethink your strategy. At the other hand, it's extremely important to discuss at least the 6-month CT scan and 1 CT scan between 2 and 4 months according to resectability. So second, what is the morbidity with neoadjuvant treatment? This is a topic that is quite often discussed, especially at surgical congresses. So this is again from the EORTC trial. It was most patients had 1 single metastasis, so it was less extended liver surgery. So this is with neoadjuvant treatment, this is without. Mortality was the same. Complication rate was a little bit higher, 60% versus 25%. There were just 1 single patient who could not undergo liver resection because he had liver damage due to chemotherapy. So if you want to ask how often does chemo harm surgery, it's sometimes the case, but in less than 1% of the patients. But it depends on the number of cycles that have been given. In the EORTC trial, these were 6 cycles before and 6 after. So this is slightly an older slide, 10 years old, but I think it's still valid. According to the chemo cycles, this is 14%, 19% with less than 6 cycles, and then the rate of morbidity increases if there are more than 6 or more than 10 cycles. Of course, these patients who had a higher number of cycles were probably also patients who had poorer baseline factors and more extended liver metastasis. Otherwise, they would probably have been resected earlier. The next question is, if we ask the other way around, how many patients get chemo after surgery, then in the EORTC trial, 36 out of 150 patients had no postoperative chemo. So this are 25%, so 1/4 of the patient. So if we assume that the chemo contributes something to overall survival, then we have to consider it. If we think it contributes absolutely nothing, that it's not important. So to deliver the chemo is one argument for neoadjuvant treatment. What is also often discussed is that we can select patients with the neoadjuvant chemo and that we operate only the good patients. I don't know whether this is a little bit a hype, because only 7% in this trial was FOLFOX only, had progressive disease. If you go for even more intense chemo, it's even less likely that you will find any patient with progressive disease. So if you don't want to operate patients with progressive disease, this is not the right strategy. Then you should go for 5FU only, but this would be a stupid one. So I think the likelihood to select patients with this approach is extremely low. So we need other, perhaps molecular parameters, which patients should undergo resection or not, but not with the neoadjuvant therapy, but to deliver the chemotherapy, to make perhaps all the resection easier because we have downsized the tumor. This is another question. The next one would be, how many time do we have? So if you plan a two-step liver resection, and for example, in addition resection of the primary, what is the time do you have to operate the patient? There we have, for this question, we have some trials where maintenance therapy was investigated. So in these two trials, this is the German trial, the AAO trial, this is the Dutch trial, this is always a continuation of 5FU plus bevacizumab, the upper arm, this is bevacizumab alone, the lowest arm is just observation. What you see is that in both trials, the median time to progression without any therapy from stopping the last cycle is 3.5 or 4 months, not longer. So it means if you stop neoadjuvant treatment and if you want to perform multiple resections like this, you need a longer time. Mostly you need for such an intervention 6 months, if you are realistic. So the likelihood that the patient will progress during this time is, as you see here, 80%. So probably it's an unrealistic schedule. So it might be much better to schedule a little bit like this, to do a first resection, then to give an additional course of chemotherapy, and then to go for the second one, or to perform, if you want to do a two-step resection, to perform the Portal-Vein embolization immediately after surgery, so at day 7, for example, to have a re-evaluation scan after 3 or 4 weeks after resection. And then if you have a sufficient increase of the liver volume, then to perform the immediate surgery within the first 4 weeks, and then to continue this chemo later, or to go this way. So, and this is again from our Salem trial, the prognosis of patients with R0 resection after neoadjuvant therapy. These are non-resected patients. Of course, all patients who did not respond to chemo are in this group. This is not only surgery. This is surgery plus good response. This is no surgery plus patients who had poor response to chemo. But there is a huge survival benefit. However, the disease-free survival after liver surgery is sometimes a little bit shorter than we think. So I think this is also important to discuss it with the patient. In median, the time is around 10 months. It's in every trial the same. It's less than 1 year. And I think it's also fair to explain it to the patient. It depends on the number of metastases and on other prognostic factors. If a patient has a very high number of metastases where you want to perform these multiple resections, then it's very unlikely that you can achieve a long-term cure. If patients cannot be resected, then it's only one way. If you want to resect them, you can shrink the metastases. So that it actually works, this has been shown in this surgical review of CT scans of the Salem trial. So we collected for the Salem trial all CT scans. We have had 5 surgeons or 6 surgeons in the room. They also could see. They all could see the CT scans. These were projected here, but we separated them by poster walls that they could not look to each other, and they had paper and they could make cross for absolutely non-resectable. In this patient, all surgeons voted for non-resectable. Here, all surgeons voted for resectable. just go for resection. And here, for very difficult, give chemo first. The light green is, I would open and see. So the left part is baseline CT, and at the right part you see how it was after chemotherapy. They were blinded, which was before and after. But you see clearly the movement towards better resectability, at least according to CT scans. So how often can we achieve resectability if we give chemo, especially intensive chemo? This is an update of an earlier analysis where we have analyzed the response rate in clinical trials according to RECIST criteria, and where the resection rate was also published. So the red trials are trials in metastatic colorectal cancer in general. The blue trials are trials that focused on a neoadjuvant treatment, so with liver mets only. So you see there's a correlation. The correlation here is much closer. If you give an intensive neoadjuvant treatment or a conversion therapy, the response rate is between 60 and 70%, and we can expect that a little bit more than 40% of the patient can achieve liver resection. In your general patient population, it should be around 15%, 12 to 15%, then you can, let's say, compete with clinical trials, and those could be an exacter number. So if we want to downsize tumors, there are two opportunities. We could give all chemo in one regimen. So these are the FOLFOX-ERI combinations. These are two Italian trials, FOLFOX-ERI compared to FOLFIRI, with or without bevacizumab in both arms. Both have demonstrated the same higher response rate, longer progression-free survival, 6 months difference in overall survival between both arms. Here, the significant nearly achieved was 4.5%. Here it was a significant difference. This is the Oliva trial, FOLFOX-ERI versus FOLFOX, both arms with bevacizumab, higher response rates. I'm not completely sure whether we need bevacizumab to increase the response rate, at least in this cross-trial comparison. Here, these are 60%, 65%, perhaps it's more or less the same. There's no trial that directly compared it. We do it in the CLM2 trial. This is a French trial demonstrated last year at ASCO. Antibody according to RAS status, doublet according to investigator's choice, and compared to FOLFOX-ERI or FOLFIRINOX, which is a little bit more intensive. Higher response rate, at least by numbers. P-value was 6%. It was the primary endpoint. Significant difference in overall survival, as demonstrated here. And there's a the fifth trial that for the randomized comparison, FOLFOX-ERI versus FOLFOX with bevacizumab in all arms. It was an American trial. Higher response rate, 60% compared to 47%. Longer progression-free survival, higher response rate in the FOLFIRINOX arm. So I think these are very good data for FOLFOX-ERI combinations, and I think it's one of the standard regimens if you want to shrink tumors. Of course, you can also combine it with cetuximab. This was our phase 1 trial, a low patient number, very interesting response rates, more or less similar results here with the chronomodulated FOLFOX-ERI plus cetuximab, 80% response rate. This is FOLFIRINOX plus cetuximab, 80% response rate, and this is the Italian group, the same as for the Falcone trials. 120 patients, response rate 70%, quite good results. If you want to combine FOLFOX-ERI to cetuximab, you should decrease the dose a little bit. We had to decrease the dose of irinotecan, or we established a lower dose than 165. We established 150 milligram per meter square. All other trials had, with this exception, they had quite high toxicity. They had to reduce the dose. They have also worked with a reduced dose for FOLFOX-ERI compared to the Falcone schedule. Now we would like to discuss a little bit more the antibodies. So perhaps this is just to remind you on the terminology. And for the next slides, then we will discuss the use of antibodies in colorectal cancer. So all antibodies you can recognize as monoclonal antibody. This is the last syllable. So And then they have two different others that have a systematic. But let's look what the antibody names mean. This is like the Greek letter for he. And it means it's a chimeric antibody, rituximab. So 2 means the antigen is on the tumor. So for rituximab, it's on B cells, B lymphocytes. It's a CD20 antibody which is located on B lymphocytes, therefore tumor cell. And this is, let's say, the given name. So with the given name Re, the tumor chimeric antibody, you have rituximab. So cetuximab has an antigen which is on the tumor cell. It's EGF receptor. It's a chimeric antibody, cetuximab. So panitumumab is also, it's more or less the same. So this is the given name, tumor is the same. The U means human, like here, and monoclonal antibody. So trastuzumab, HER2 is on the tumor cell. The Z means humanized, as here. Monoclonal antibody. Bevacizumab, humanized antibody, something with circulation. It's VEGF, the target structure. And then there are some who have inflammation, something from the inflammatory system. So, for example, infliximab, which you know, chimeric antibody, it's used, for example, in Crohn's disease. The same for adalimumab for rheumatic disease. Inflammation, the L, a human antibody. And these are all these PD-1, PD-L1 antibodies. They have their target structure in the immune system, so something with inflammation. So therefore, they all have a Li. So pembrolizumab, avelumab, and so on. Just that you have a little bit of impression how to select the antibody names. So this is cetuximab, the EGF receptor antibody, because it's tumor, chimeric, and so on. So you know, for cetuximab, we have to determine KRAS. So it's absolutely not working in RAS mutant patients. This is for last line treatment. In patients who are just KRAS exon 2 wild type, it doubles the overall survival in last line from 5 to 10 months. It's quite good. For first line, it's also very important to determine the RAS status. This was the first publication of the Crystal trial. Overall survival with cetuximab plus FOLFIRI versus FOLFIRI alone. Very small difference of 6 weeks. So if we determine the KRAS exon 2, and if we select the better 60% of the patients, then the survival difference becomes 3.4 months, which is a substantial benefit or a higher benefit. And then with all RAS wild type patients, the survival difference is 8 months, which is really substantial, much more than for the bevacizumab trials, for example. So here the patients have a major benefit for RAS. And of course, I think it's also in Taiwan in the label to determine RAS status before an EGF receptor antibody is given. Now I would like to discuss a little bit whether we could even more select the patients. And this comes to the question, where's the primary tumor located? You as surgeon know that patients who have right-sided tumors have always a little bit of worse prognosis than patients with a tumor on the left side. So this was the first analysis of the Crystal trial, and there was the observation made that the patient with left-sided primary tumors have a benefit if cetuximab is given compared to chemo alone, but that there was no benefit for right-sided tumors. No one would believe it, because it's just one observation. We have never considered it in chemotherapy. This is the last line trial, which I have shown before. Cetuximab plus best supportive care versus best supportive care alone. Longer overall survival for left-sided tumors. No benefit for right-sided tumors. Now we have the second trial, which is very interesting. Would you now believe it? I have more trials, so it's no problem. So this is the comparison of FOLFIRI cetuximab to FOLFIRI bevacizumab, the FIRE3 trial. Primary endpoint was response rate, was not met, but huge difference in overall survival, 8 months between FOLFIRI cetuximab versus FOLFIRI bevacizumab, no difference in progression-free survival. How is it with the sidedness? Patients who have left-sided tumors have a benefit from cetuximab, The orange curve is cetuximab. This is bevacizumab, which was better. A significant difference, nearly 1 year difference between both arms. This is the right-sided tumor. Cetuximab is the lower curve. Bevacizumab is the other curve. So now we have the third trial. It's still not the last one. For panitumumab, only very few patients were left, so for sidedness, therefore the confidence interval is huge. I will show it later on. This is a CLGB trial, you remember, higher response rate, no difference in progression-free survival, a small benefit in overall survival. Hazard ratio was not 1, it was 0.9, which is a difference. So by the way, we have now 3 trials, more or less, all of them showing a survival difference, but for the sidedness, it was demonstrated at last ASCO. Left-sided tumors with cetuximab, better than with bevacizumab. A difference here of 7 months, even in the CLGB trial, which was negative for the primary outcome. But if you just go for left-sided tumor, this is a significant difference with a hazard ratio of less than 0.8. For right-sided tumors, bevacizumab is much better than cetuximab. This difference was not significant, but I would not give cetuximab in right-sided tumors in first line. So if we combine everything, these are the trials for which compare anti-EGF versus anti-VEGF, left for CLGB, right, fire 3, left, right. This is a peak trial with the huge confidence intervals. This is cetuximab for the crystal trial, cetuximab plus chemo versus chemo alone, left, right. This the panitumumab trials, left, right for the second line trial. And if you combine everything, a huge benefit, hazard ratio 0.75 for left-sided tumors if you start with cetuximab. For right-sided tumors, rather a detrimental effect. So this led to our statement in the AEO, which is a German study group for RAS wild-type left-sided primary tumors. This is our preferred combination because of the huge survival difference for first line. For RAS wild-type right-sided tumors, we don't give anti-EGFR combination, we give anti-VEGF. And for RAS mutants, of course, too. For second and third line, there was no statement made. I think with the last line trial, it would be logical also not to give it in third line. So what is the background for this? I don't know. I even don't know whether this consensus molecular subtypes explain it. We will see data on the subtyping during this year, but I'm not sure whether they will explain it. We will learn on it. There are, of course, some mutations that are not equally distributed. The number of BRAF mutation in the right-sided tumors is too low, still too low to explain it. Of course, there are much more BRAF mutant patients on the right side. So this is from the spectacular. So we have what we have there is, or what we have observed, there are also some colorectal cancer patients who have BRCA mutations, although a little bit more on the right-sided tumors. There are some patients who have HER2 mutations or amplifications. FGFR, there are drugs for lung cancer are there. MSI high, the number is relatively low, but it's very interesting, and I would like to focus for my last slides on some issues in the subgroups of BRAF mutant, HER2 amplified, and MSI high patients, because they are very interesting. All other study groups are at the moment rather for clinical trials. So the second group, which is very interesting, is HER2. There are some patients, I have shown, these are around 3% of the patients who have a HER2 overexpression. The red patients are those with HER2 3+. You see they have a response to treatment with trastuzumab plus lapatinib. And this is a spider plot where you have to wait for the later analysis. And then the third group are the patients who have microsatellite unstable tumors. If these are the samples, the tumor samples, then, and this is the number of mutations. There's one group, it's the red one, with a very high number of mutations, and these are the microsatellite unstable patients. They have a problem with their DNA repair mechanism, therefore they have much more mutations, The pool E mutated patients have even more. And then they have not only more mutations, they have also more neoantigens that can be recognized by the lymphocytes. And this is probably the explanation why the PD-1 blockade is active in these patients. These are patients with colorectal cancer who are microsatellite stable. They seem to have no benefit or no real benefit. Very few patients with a very minor response. These are mismatch repair deficient or microsatellite unstable patients with colorectal cancer. The blue one and the black one are non-colorectal cancer patients who are microsatellite unstable. So this was the publication from the New England Journal. Last ASCO there was an update. The green one are the microsatellite unstable colorectal cancer patients, and they have a quite good progression-free survival compared to the proficient patient. I think these are promising results. We will see how we will end up with the tumor immunology. So PD-1, PD-L1, and CTLA-4 is by far not the end. There are much more receptors you can block, and where already antibodies exist, partly in phase 3 trials. So it will be a very interesting field over the next time. So I want to come back. It's extremely important to treat the patient with the appropriate medical treatment, but also to have a very good multidisciplinary cooperation. This methodology you know already. It was applied to the FIRE3 trial. This are the baseline CT scans. You see there's a small group of patients where we had absolutely no idea why they had no resection of the tumor and of the primary. So this was a surgical review. The yellow part is when more than 50% of the surgeons voted or the reviewers voted for resection in one organ disease before treatment and after. So perhaps 2/3 of the patients could have at least be in-depth evaluated for liver surgery or for other surgery in the FIRE3 trial. If there was a 2-organ disease, it was still 50% of the patients. With 3-organ disease, it became a little bit more rare. So this is one slide which shows the same according to the setting where the patient were treated. This is the review and the secondary resection at best response, so when they had the maximum response. The reviewers recommended evaluation for resection in 50% of the patients. Actually resected were 25% of the patients who were treated in university hospitals, 16% of the patients who were treated in non-university larger hospitals, and 10% of patients who were treated in private outpatient oncologists. So this is, you can assume there is substantial risk in some treatment settings that surgery is not offered to patients, and I think this demonstrates how important this multidisciplinary cooperation is, and obviously it's working in some settings a little bit better than in other ones. If you combine everything, the better medical treatment, the better multidisciplinary treatment, we can improve the survival. So this is from the first trials with best supportive care versus 5 of you, 8 months, 12 months median overall survival. This is the Tony Gong trial for FOLFOX or FOLFIRI or vice versa, with 20 months median overall survival. This is the CLGB trial, left-sided tumors with cetuximab, bevacizumab, right-sided with the 2 antibodies, and just to show how the treatment has been evolved. This is, let's say, first-line hemodialysis in renal failure patients. So in the left-sided tumors that are appropriately treated, the prognosis of the patient is as good as for patients who start hemodialysis for renal failure. I think this is a little bit promising that we have, let's say, converted the disease to a chronic one. Thank you very much.